Safety and Health, United Nations Secretariat in New York, from the Public Health Unit. I welcome all of us to this another edition of our monthly HIV program webinar. And one of the things that we've started doing is to actually start to focus more on HIV program implementation in our duty stations and missions globally. And we started some series January this year, and we had another session in February, and this is the March edition of the same HIV series. Today we have Professor Dr Masci, who is a professor of infectious disease in the United States, and who has had a lot of experience and vast experience in program implementation and management of HIV program, both locally within the US and globally. And is more or less like an oracle in the field of HIV program and HIV program implementation. Without further ado, today, what we'll be dealing with today is HIV clinical manifestation, clinical diagnosis, and HIV infection progression. So Professor Masci will be taking us through this series, and thereafter his presentation, we'll have some time for question and answer. Prof, over to you. Thank you very much.
Dr. Joseph, you can start now.
Can anybody hear me?
Yes, I think we can hear you.
Yes, we can hear you.
Yes, we can hear you.
Thank you. I haven't been able to hear anything. I just am trying to get confirmation that I should start. Is it okay for me to start now?
You can start, because we mute everybody so that there won't be interference with your presentation.
Okay.
Yeah. Thank you.
Right. Today we're going to talk about modern approaches to the diagnosis and treatment of opportunistic infections. Can I have the next slide? This is the most recent data on the global HIV/AIDS epidemic and where things stand. And this is obviously all before COVID. So this is perhaps not completely accurate as of today. Go back to the previous slide. Previous slide, please. Yes. And as you can see, the concentration is where it has always been in Central and Southern Africa. Next slide. If you compare the number of people living with HIV several years ago, Eastern and Southern Africa has far more people living with HIV than any other part of the world. And I think we all know this. Next slide. If you look at the amount of money that ART costs for adults, the projection for 2020 was this much. That's in millions of dollars. Next slide. Now on this slide, there's actually some good news. The number of people living with HIV, as you see, is going up. But that's because of the results of effective ART. We're treating many more people effectively than we were even a few years ago. But new infections with HIV/AIDS still about 2 million a year, and deaths from HIV/AIDS still about 1 million a year. Next slide. These are the top selling HIV ART drugs. I think you're pretty much familiar with all of these. The trend over the last 5 years has been towards simpler regimens, often once-a-day regimens, and that has greatly facilitated the treatment of these patients in countries that have access to those drugs. Next slide. So how are we doing in progress toward the 90-90-90 target? Well, as we see, the progress is not that great. If you look at these striped bars everywhere in the world, we're still falling short. And the 90-90-90 target that was initially 2015 and then moved to 2020 is now 2025. And it's largely due to the unavailability of effective antiretroviral treatment or of processes to actually provide effective antiretroviral treatment all over the world, but particularly in Eastern and Southern Africa, Asia, and the Pacific. Next slide. Now, new infections among children. This is good news. With and without the provision of antiretroviral medicines, this comprises a 20-year period where we were learning how to prevent maternal to child transmission, and 1.6 million new child HIV cases were averted. Next slide. Percent of women receiving antiretroviral medicines. This is really one of the triumphs of all of this, but still we see differences in different parts of the world. Now this graph stops in 2015. The Middle East and North Africa is well behind the global pattern, but Eastern and Southern Africa has done well in this. And this has been one of the major triumphs of HIV treatment, preventing vertical transmission. Next slide. So why are we still talking about opportunistic infections? Well, here's why. In the United States, 77% of known HIV-infected patients who are retained in care and take their therapy are virologically suppressed. That leaves 23% who are not. In the United States, approximately 20% of persons are completely unaware of their HIV infection. Many of these present with HIV-related opportunistic infections, and I work in a large city hospital in New York, and we still see all the traditional opportunistic infections, just in smaller numbers than we used to see. Other patients who are aware of their HIV status, but who do not take their prescribed medication or do not achieve adequate immune reconstitution may also obviously present with these HIV-related opportunistic infections. Next slide. Okay, so these are the infections. These are the infections that I'm going to talk about: pneumocystis, toxoplasmosis, cytomegalovirus, Epstein-Barr virus, herpes simplex, cryptococcal meningitis, atypical mycobacterial infection, and the cryptosporidias, microspordiosis, isosporious group. Next slide. So pneumocystis carinii pneumonia. Approximately 90% of cases occur in patients with CD4 count less than 200. Now, it's really important to recognize how rare pneumocystis is outside of the HIV epidemic at all. It was such an obvious change in what we were seeing nationally in 1980, where we suddenly started seeing this infection in people all over our country, where the total number of cases had been in the low hundreds up until then. It suddenly rose to the tens of thousands. So CD4% less than 14 increases the risk even further. And most cases nowadays occur in patients who are unaware of their HIV infection or not receiving consistent care, or who have a CD4 count less than 100. The clinical features in mild cases, dyspnea may be the only feature. Fever and hypoxemia are also characteristic though. Elevation of lactate dehydrogenase to greater than 500 is something we've used from the beginning. It's unusual to have a normal lactate dehydrogenase, at least over the first 72 hours in a case of pneumocystis. It's far more commonplace to have a lactate dehydrogenase over 500. And of course, the diffuse ground glass infiltrates that are seen on X-ray and CT that we're all familiar with. But the clinical features are nonspecific, and definitive diagnosis has to be sought. Now, this is particularly true in the setting of COVID, where we see diffuse infiltrates, and we have to be careful. We've already at our hospital had 2 patients with HIV-related pneumocystis, initially misdiagnosed as having COVID infiltrates. They were not treated initially, and one of them got very, very sick before it was recognized that he actually had pneumocystis. He recovered, thankfully, but in parts of the world where a lot is being seen of both infections, particularly Southern Africa at this point, it's very easy to imagine HIV-related pneumocystis to be confused with COVID-19 related pneumonitis. Next slide. So this is the picture we're all familiar with. That's a relatively mild case on the left, relatively severe case on the right. These diffuse infiltrates are obviously not specific for pneumocystis. We rely a lot on prevalence of disease in our community to figure out what could be causing infiltrates. And since prevalence of disease among AIDS patients with CD4 counts less than 100 points to pneumocystis, that's how we make the diagnosis clinically. But obviously the X-ray we're seeing on the right could represent lots of different things, including tuberculosis in an immunocompromised host, histoplasmosis, and as I said, now COVID-19. Next slide. So how do we make the diagnosis? Histopathologic or cytopathologic demonstration of organisms in bronchoalveolar lavage fluid is very sensitive. Lung biopsy is very sensitive. Sputum is required. One of these is required for definitive diagnosis. Sputum, even in our modern laboratories, we've had trouble making this diagnosis with sputum alone. Polymerase chain reaction is sensitive and specific, but cannot always distinguish between colonization with pneumocystis, which many of us might have, just as an incidental finding, and beta-D-glucan, which is a component of the cell wall of pneumocystis, is usually elevated, but that's not a test that's available all over the place. Next slide. So if bronchoscopic specimens are available, that certainly helps answer the question, what is causing the infiltrates? Trimethoprim sulfa is the treatment of choice, of course. And although resistance mutations have been observed, thank goodness, no clinically significant resistance has been documented. In 40 years of the AIDS epidemic, there's been no clinically significant resistance of pneumocystis to trimethoprim sulfa. Alternatives for mild to moderate disease, dapsone, atovaquone, or clindamycin primaquine. Alternatives for moderate to severe disease, which is a PO2 less than 70 or AA gradient greater than 35, include clindamycin primaquine or IV, but not aerosolized pentamidine. Patients with moderate to severe disease should also receive corticosteroids within 72 hours of initiating therapy. Salvage therapy for patients failing trimethoprim sulfa typically means clindamycin primaquine. Next slide. So when should we start antiretroviral therapy in a patient who's recovering from pneumocystis? We should start it quickly. There's no downside to starting antiretroviral therapy within 2 weeks of the diagnosis. There's no indication of acceleration of this infection. There's a lower incidence of progression of AIDS or death. So as soon as we get ART in these patients, the more rapid their overall recovery will be. And as you'll see from many of the infections we're going to talk about today, ART has really been a lifesaver. Now you can't always start ART immediately like this with every opportunistic infection, and we'll talk about those in which it can't be done. But with pneumocystis, it's really important to start it almost immediately. Next slide. So toxoplasmosis, this is a protozoan parasite that can cause acute congenital chronic or reactivation disease. Primary infection occurs after eating undercooked meat containing cysts or ingesting oocysts that have been shed in cat feces. And many of us have had primary infection with toxoplasmosis without knowing it. There are other sources in the environment. These are also rare ways of getting it. Up to 50% of people with documented primary infection don't have any identifiable risk factor. The organism is not transmitted from person to person. Neither is pneumocystis, by the way. In the setting of AIDS, this infection is almost always the result of reactivation of latent infection and presents as cerebral infection. And prior to the advent of effective antiretroviral therapy and suppressive therapy, the annual incidence among HIV-infected patients was approximately 33% who were seropositive and had profound immunosuppression. And by profound, I mean below CD4 counts of 50. Now, before we go to the next slide, it's really important to note the similarities between this and pneumocystis, and that both of these are infections that are commonly present in the human population as asymptomatic infections. And both of them activate in a very, very specific way in the setting of HIV. Toxoplasma brain abscesses, which I'll show you, that's not something we really ever saw prior to HIV. Now with other diseases that require advanced immunosuppressive therapy, perhaps, but still largely focused on HIV. Next slide. So here we see the typical CAT scan of a patient with toxoplasmosis. It's lesions, usually multiple, usually near the basal ganglia. And here we see the brain biopsy. This is a toxoplasma cyst. Next slide. And you can have actually two things that coexist. And two things that look very similar are toxoplasmosis and CNS lymphoma. So here we see toxoplasmosis in a basal ganglial area, CNS lymphoma in a frontal lobe area, with and without contrast. Next slide. The way to distinguish these brain lesions is with a PET scan. Toxoplasmosis does not light up. Lymphoma very dramatically does light up with a PET scan. In the setting of AIDS, infection is almost always the result of reactivation of latent infection, and it presents almost always as cerebral infection. Prior to the event of effective antiretroviral therapy and suppressive therapy, the annual incidence was 33% among patients who were seropositive for Toxoplasma gondii. Now, seropositivity is really common in the general population, over 70% in many areas of the world. Patients with CD4 counts below 50 were at great risk for these CNS manifestations. Next slide. So here are the clinical manifestations: focal encephalitis, and these are the clinical features: headache, confusion, motor weakness, and fever. Now, all of these may be late features, well after the CNS infection has actually started. Non-focal encephalitis can also occur with psychiatric symptoms and nonspecific headaches, stupor, coma, and death as the disease progresses. Computed tomography typically demonstrates, as I've shown you, one or more ring-enhancing lesions or diffuse encephalitis. Next slide. So what looks like it? Well, CNS lymphoma and progressive multifocal leukoencephalopathy. The definitive diagnosis of toxoplasmosis requires demonstration of the organism within a cerebral mass lesion. However, that's very, very difficult to accomplish, and it's almost never necessary because characteristic lesions on CAT scan or MRI are typically in the basal ganglia. So in an AIDS patient, especially with an AIDS patient with a severely depressed cellular immune system, when we see ring-enhancing lesions in a brain image, we can assume it's toxoplasmosis until we document that there's been no response to treatment. But PET scanning or SPECT scanning can help distinguish brain lymphoma from toxoplasmosis. PML lesions typically occur in the white matter and produce no edema and no contrast enhancement. The detection of Epstein-Barr and JC virus in the cerebral spinal fluid is also suggestive of CNS lymphoma. But it's rare that we have to go that far to actually exclude CNS toxoplasmosis. Most patients will respond to treatment in a fairly dramatic way with improvement in their CNS lesions when the treatment is focused on toxoplasmosis for a few weeks. Next slide. So cytomegalovirus, this is the largest DNA virus that infects humans. Prevalence, again, like these other two infections, is very, very widespread in the normal population. Active disease in the setting of HIV infection, though, typically represents reactivation of latent infection, just as it does with toxo and with pneumocystis. It's most often seen in patients with a profound depression of CD4 count, less than 50, and before effective antiretroviral therapy, 40% of HIV-infected patients in the United States developed Cmv retinitis. That represents 85% of CMV infections in HIV-positive patients. In other words, back before we had effective antiretroviral therapy, CMV infection was very common, and it was specifically epidemic in retinal infections. But since the advent of effective ART, new cases have fallen to less than 6% in the United States. Next slide. So the symptoms: painless progressive vision loss, floaters, or visual field defects. Typically, it begins in one eye and then in both. The examination reveals a cream or yellow-white area on the retina with perivascular hemorrhages and exudates. If these lesions are peripheral, they may not affect vision early and may progress a lot before any obvious vision loss develops. Floaters are very common in everybody, and they can be a hard thing to distinguish in the HIV patient. So when we saw a lot of this, it was because of routine screening that we did for it, or because of sudden vision loss. Next slide. So this is the therapy. For small and peripheral lesions, valganciclovir for 14 to 21 days, then one daily until the CD4 count gets over 100. For sight-threatening lesions, intravitreal injections with ganciclovir or foscarnet may be necessary. That's ganciclovir PO/BID for 14 to 21 days, then once daily after that. Second-line agents like foscarnet and cidofovir are available, but it's rare that we have to resort to those. Next slide. For non-ocular disease, this is specifically true for GI infections with CMV, like colitis or esophagitis, ganciclovir or foscarnet for 21 to 28 days. And for neurologic disease, this is usually a non-specific cerebritis, foscarnet until symptomatic improvement. But just as I pointed out with Cmv retinitis, as the CD4 count improves with effective antiretroviral therapy, all of these conditions get much less likely. So effective antiretroviral therapy, again, is key in controlling CMV infection. Next slide. So these are ulcerations in the esophagus caused by CMV. Next slide. Herpes simplex virus is not as common and not as specific for HIV infections, but it does occur in a more severe variant, often an atypical variant in the setting of HIV. And this is particularly true with anogenital lesions, which can be caused by either HIV-1, rather that should be herpes simplex 1 or herpes simplex 2, and may be particularly severe and refractory to treatment. Other sites of involvement include keratitis, meningitis, encephalitis, radiculitis, and esophagitis, especially if the CD4 count is less than 50. We've had very, very problematic cases of herpes simplex in the perianal area, particularly of gay men who had fully restored immune systems, but still could not control the herpes simplex infection in the anogenital area very easily. This is a virus that can get resistant to common treatments, and it is much more problematic than other opportunistic infections as the CD4 count rises to normal. Next slide. So here's the typical features. It's typically an infection that's diagnosed clinically, as you can see in this picture here. Nobody would have any doubt that this is probably perianal herpes. It's one of the first infections that was demonstrated in AIDS back in the early 1980s. But if you have lesions that are that have a roof to them, you can unroof them and do a zinc prep. This is a methylene blue stain. And viral culture, obviously, and PCR is also available. But it's usually the clinical appearance of these lesions that strongly suggests herpes. Next slide. So here's the treatment, acyclovir, valacyclovir, or famciclovir. For oral labial lesions, this treatment is relatively straightforward, but for genital lesions, either initial or recurrent, this can turn into chronic suppressive therapy after initial regimen of 5 to 10 days. Severe mucocutaneous lesions should be treated IV, followed by oral acyclovir. Esophagitis you see for 14 to 21 days, encephalitis or hepatitis, 21 days. For acyclovir-resistant strains, the most effective drug is foscarnet. This is a drug that has its toxicities, but as I said, herpes simplex, unlike pneumocystis, which has not developed any clinically significant resistance, herpes simplex is commonly resistant to acyclovir. Next slide. So the JC virus, this is a CNS virus, again, was very, very rare before the AIDS epidemic. It causes a condition called progressive leukoencephalopathy. The incidence is declining dramatically with effective antiretroviral therapy. The symptoms are vague. They include headache, particularly movement disorders like ataxia, difficulty speaking, hemiparesis seizures. Fever is only seen rarely, though. The diagnosis is made by CT or MRI, which demonstrates white matter lesions without any edema around them. Unlike the ring-enhancing toxo lesions or the edema-surrounded lymphoma lesions, these are lesions that look silent. They're white matter lesions, with no surrounding edema. CSF may demonstrate JC virus by PCR. That's not necessary, but it may be you may be able to demonstrate it. And antiretroviral therapy with immune reconstitution is a very effective treatment for PML. Next slide. So here we see PML. Now on these scans, you see these lesions bifrontal. And these are clinically often silent lesions. There's no edema around them. There's no ring enhancement. There's one in the basal ganglia. A patient that I had before we had effective antiretroviral therapy was a young man who was a professional who began to notice that he was getting increasingly confused during the day. That was his only symptom. Then he began having memory loss. That was an add-on symptom, but was not accompanied by headache or focality. And he had JC papovavirus infection and PML. And unfortunately, he died before we had effective antiretroviral therapy of this condition. Next slide. This slide is a little out of place. Epstein-Barr virus and B-cell lymphoma. I won't go into this in great depth. Epstein-Barr virus mediated oncogenesis responsible for most cases of primary central nervous system lymphoma in AIDS. Prior to modern antiretroviral therapy, this form of lymphoma was over 1,000-fold more common in the setting of HIV. So most of the CNS lymphomas we see back in the era before we had effective antiretroviral therapy, when we saw a lot of them, were caused by Epstein-Barr virus. The incidence of this CNS-related lymphoma has decreased by 90%. Clinical presentation is similar to PML, but because of the predilection for the brainstem and basal ganglia, cranial nerve palsies are also seen. And this is typically seen with a median CD4 count of 50 or less. Next slide. Diagnosis, you see the means of making the diagnosis here. CSF PCR for Epstein-Barr virus DNA is sensitive and specific. PET scanning can help distinguish it from CNS lymphoma and from toxoplasmosis, but stereotactic brain biopsy can provide the definitive diagnosis, but may not be needed if imaging and the CSF PCR are positive and serotoxo antibody is negative. Next slide. So here we see some pictures of primary cerebral lymphoma. Here you see it involving the meninges in particular. Here you see mass lesions, which can mimic, obviously, toxoplasmosis. Can also coexist with toxoplasmosis, and that always has to be a concern. Next slide. So these are some other lymphomas that have increased prevalence in the setting of HIV infection. Burkitt's lymphoma, another Epstein-Barr related one, diffuse large B-cell lymphoma, primary effusion and plasmablastic lymphomas. These are all lymphomas that are relatively common, especially diffuse large B-cell. We occasionally see that in a patient and we sometimes forget to test for HIV, but it's usually not associated with HIV. It's a common lymphoma in general, but it's never a bad idea to test for HIV if you see diffuse large B-cell lymphoma or Burkitt's lymphoma. Next slide. Cryptococcal infection. Now, before there was effective antiretroviral therapy, between 5 and 8% of HIV-infected patients developed cryptococcal infection. Now, over 1 million cases of cryptococcal meningitis worldwide are diagnosed among HIV-infected patients annually, almost all among patients with CD4 counts less than 100. Any organ in the body can be infected, including skin. Next slide. Skip this slide. This belonged elsewhere. Next slide. But it's, no, next slide. Go to the previous slide. Go back to. Okay, these pictures, to the pictures. Go forward one. Sorry. Here we are, stop. So here we see the organism in an India ink stain and the spinal fluid, the budding yeast cells that we've all seen. Here we see a localized area of cryptococcoma, it would be called, in the brain. Those are not typically seen. It's most often this meningitis. If you see these organisms on an India ink stain, that is typically bad news and it suggests very advanced cryptococcal infection. Lesions can also be seen in the lung and in the skin. But like pneumocystis affects the lung and not much else, and like toxoplasmosis affects the central nervous system and not much else, cryptococcosis, to the extent that it's a significant illness in HIV, affects the brain and not much else. Next slide. So how do you make the diagnosis? There's increased opening pressure seen in most patients. The ink stain is positive of the CSF in over 60%. The culture is positive in 95%, but the growth can be slow. It may take a week. Serum cryptococcal antigen, though, is almost always positive and can be used for screening. Now, this is a really important lab test. The serum and CSF cryptococcal antigen, since this is an antigen test, not an antibody test, it actually detects the organism, not the immune reaction to it. So there are very few false positive cryptococcal antigen tests, and we can judge by the titer of the cryptococcal antigen how advanced the infection is. We've seen CSF antigens of greater than 1 to 128,000 titer in severe cases here. That was a case that was rapidly fatal. But we've also seen CSF antigens that sort of wavered in the lower range during treatment with no clinical manifestations of worsening, even when the antigen level was higher than it had been a week before. So the serum cryptococcal antigen is a really important thing to know about and to follow. It's a cheap test. It's a latex fixation test, and we can follow it in the serum as well as in the spinal fluid. Next slide. The therapy consists of 3 phases: induction, consolidation, and maintenance. If the CSF pressure is high, you have to reduce it first, and that may require daily lumbar puncture or even a ventriculoperitoneal shunt. Corticosteroids don't work to reduce CSF pressure in that disease. CSF pressure can also be lowered in patients with confusion, blurred vision, papilledema, etc., even if you have not documented greater than 250. The induction phase consists of a minimum of 2 weeks until cultures are sterilized. Flucytosine and amphotericin lipid complex, or amphotericin alone, are the treatment. Consider repeat LP to determine if the organisms are gone. The consolidation phase is 10 weeks of fluconazole. And then secondary prophylaxis until the CD4 count is greater than 200 for more than 6 months is daily fluconazole. Next slide. The immune reconstitution syndrome is particularly common in patients with cryptococcal infection. And this is one of the infections where we have to be careful in when we actually institute effective antiretroviral therapy, which can result in rapid immune reconstitution. The patients present as worsening infection despite evidence of microbiological improvement. So we see, for example, a India ink stain that reverts to negative, and yet CNS signs are getting worse. It's most common in patients who have an initial high viral load with HIV and minimum evidence of inflammation in the CSF. The risk is lower in patients with negative CSF cultures. It can be difficult to distinguish this from treatment failure. So the treatment is to continue antiretroviral and antifungal therapy and reduce the CSF pressure with corticosteroids. Next slide. So immune reconstitution recommendations: when do we start ART in patients with selected opportunistic infections? Well, as I said, with pneumocystis, you could start it almost immediately. With toxoplasma, many clinicians start ART also within 2 to 3 weeks. And with tuberculosis, also within 2 to 3 weeks. Really, it's with cryptococcal meningitis where delay starting ART is particularly important, where progression or the immune reconstitution syndrome can produce dramatic deterioration. Now, immune reconstitution can be controlled by the addition of corticosteroids in some patients. It rarely requires stopping the antiretroviral therapy completely, as long as we've waited a decent interval after treatment for cryptococcal meningitis. But it can be a dangerous syndrome, particularly in Cryptococcus. Next slide. Atypical mycobacterial infection. This is typically with Mycobacterium avium intracellulare. Here you see it in a, I guess this is a lymph node biopsy. These acid-fast organisms all over the place. It has a characteristic shape that microbiologists can distinguish it from MTB, not with 100% accuracy perhaps, but there are clues. And these are skin lesions that can also be seen with atypical mycobacterial infection. Atypical mycobacterial infection, as you know, is caused by a number of different species in addition to avian intracellulare. But in HIV, it's almost always caused by avian intracellulare. Next slide. So the common sites of infection are the skin, the lymph nodes, the lymphoid tissue, and the GI tract and bone. It's almost always, as with most of these other opportunistic infections, found in patients with CD4 counts less than 50. The presentation is often very nonspecific, with fever, weight loss, and hepatosplenomegaly. And it may present after antiretroviral therapy has been started as a result of immune reconstitution. Other atypical mycobacteria that can be associated with HIV include Mycobacterium kansasi and Mycobacterium zenapi. Next slide. The therapy, clarithromycin or azithromycin plus rifampin and ethambutol. For zenapi or kansasi, you see the regimens here. Now, these regimens are difficult to maintain a patient on. That's why it's so important to work hard to get the CD4 count over 100 so that therapy can be stopped after 6 months. Immune reconstitution syndrome presents typically with fever and lymphadenopathy. Since this is not a brain infection, immune reconstitution doesn't present with that really serious brain problem that you might see in a cryptococcal case, but immune reconstitution can occur with this, with these nonspecific symptoms. Next slide. So cryptosporidiosis, microsporidiosis, isosporiasis, these are infections that are increasingly being recognized in normal hosts, actually, all of them. Cryptosporidium on the left here was the first one that was recognized in HIV as a very largely opportunistic infection. Produced diffuse, watery, incapacitating diarrhea. These are microsporidia. This is isospora. They can all produce that same illness. So it's always important when you see an AIDS patient, who, particularly with a CD4 count less than 100, who's complaining of watery diarrhea, that we look for these. You're not going to see these on a stool culture or even over a parasite test. You're only going to see these if an acid-fast stain is done of the stool to identify these organisms. Next slide. All of them cause diarrhea. They all can cause extraintestinal infection. That's particularly seen with microsporidia, although that's rare. The treatment, the only effective treatment is antiretroviral therapy for cryptosporidiosis. Again, really important to address that quickly and work hard to get the CD4 count over 100. For microsporidiosis, albendazole can be effective and immune reconstitution again. Albendazole, we don't know exactly how long it should be treated, but unlike cryptosporidium, at least we have a medication to treat microsporidiosis. Next slide. So I'll thank you there. It's a complicated array of infections. Fortunately, in areas of the world with good control of the HIV epidemic, we see less and less of this. We used to be completely inundated here. There was a time at my hospital where we had over 200 cases of pneumocystis in the hospital at the same time. So this is something to be respected, particularly in areas where any retroviral therapy is hard to get. In your UN staff, you're unlikely to see any of these infections unless you have people who've never been HIV tested and have gotten to a point of severe immune disabilities before any consideration of HIV testing was even made. So I'll stop there and see if there are any questions. I hope I can hear them if there
are. Thank you so much, Prof.
Can't hear you.
Yeah, we can hear you, yeah. Thank you so much, Prof, for the detailed presentation. Colleagues, you've heard from Prof.
I'm sorry, I cannot hear you.
Hello? Hello, can you hear me now?
Fola, we can hear you. Prof, can you hear us? Can you hear me?
Yes, we are hearing you.
Hello, can we all hear me now?
We can hear you, but we seem to have a problem with Professor Masci.
Dr. Fola, maybe you can call Dr. Masci so that he can maybe increase his volume.
If I can do what?
If you can call him.
Doing a lecture, I'll call back. Maybe I should just look in the chat and see if there are any questions there.
Yeah, okay. Maybe colleagues, if you have any question,
Okay.
You can put them in the chat.
Can you highlight ART as prevention?
Yeah.
Yes, well, it's certainly ART as prevention, as we've seen in PEP and PrEP, is really very, very important. As we've seen in treatment of mothers who are delivering, it's very important to prevent HIV infection in children. PEP and PrEP in our hospital, we put a lot of emphasis on this, particularly on pre-exposure prophylaxis among people who are engaging in high-risk behaviors, and it has been very effective. Obviously, people have to be maintained in care in order to provide this, but it is very effective, and we should always consider it as an important strategy in communities where HIV infection is uncontrolled. We will share the document. Okay, any other questions? Share them in the chat.
Do we have any other questions, please? You can put it in the chat, or you can read them aloud, and I can type it out for Prof to see. Okay, you can ask your question. Yep. Park RDB Sanch, can you ask your question, please?
Hello.
Hello.
I am Dr. Simon Bal from Park RDB6 Sange. There is so much distortion just because of.
If you have any questions, please just put them in the chat.
One friend from the doctor. The question is, can the saliva then?
Can you come again? We cannot hear you.
Yes. There is so fast training. My question is, can HIV/AIDS transfer from the saliva of patient to other person?
Okay, I'm not seeing any more questions. Oh, here. Seems like there are some problems with audio settings at your end, as you can't hear us. I've tried everything I know how to try with the audio settings. They're all on right now, so I'm sorry. Can HIV/AIDS be transmitted with patient saliva? The answer is no. Okay. That was obviously a fear early in the epidemic, but it's been clearly shown it can't be transmitted that way. Any other questions? Sorry for the audio problems. Is it preferable to treat opportunistic infections before starting a patient on ART? This is particularly the case with cryptococcal brain infection, because iris can be extremely severe in those cases. With most other infections, pneumocystis, toxoplasmosis, ART can be started after 2 weeks of treatment of the primary infection. We just have to look for potential consequences of immune reconstitution. Immune reconstitution is more common than we once thought it was, but it's less feared than we once thought it was. It's usually easy to control it by the addition, if we have to, of corticosteroids or other anti-inflammatory drugs. It's very rare that we actually have to withdraw a treatment, except in the case of cryptococcal infection. Is there any specific strategy to motivate people living with HIV to start and adhere to antiretroviral treatment? The best strategy is to show them how their life can be very, very much prolonged by using effective antiretroviral treatment. The statistics on that is that a person who is 20 years old and is HIV infected, who started on effective treatment, actually lives longer than the general population, out to the high 70s rather than the low 70s. So that's a statement that may mean some to others, some patients, and maybe not to others. But if you have examples of patients who are taking the medication and are doing well, sometimes they are your best ambassadors. Is there any expectation of a vaccine? There's been talk about that for 40 years. We're no closer to a vaccine than we were a few years ago. The question is why? The answer is HIV is such an unusual infection in that it is primarily an intracellular infection for almost the entire duration of the infection. And having a vaccine that actually eliminates an intracellular infection is very different from having a vaccine that eliminates an extracellular infection like COVID-19. COVID-19, the vaccine studies have been incredibly effective, but for HIV, we don't have an effective vaccine, and I don't think we're going to have one anytime soon. You had mentioned TB in the presentation. Is that an infection you commonly in your practice in HIV infections see? Yes, well, TB is common in our community anyway. We see severe cases of TB, particularly with extrapulmonary involvement, especially with CNS involvement, and it can occur really at any CD4 count. But the very severe cases, as is the case with the truly opportunistic infections, occur with CD4 counts below 100. That's where we see diffuse pneumonia with hypoxemia or severe meningitis. But you always have to be careful because tuberculosis can cause, there's a lot of overlap between what tuberculosis does in the HIV infected world and what it does in the rest of the world. And since TB is so common all over the world, it has a lot of variant findings, even in HIV negative people. But in HIV positive people, particularly with low CD4 counts, it can be extremely aggressive. What are the emerging trends regarding COVID-19 and HIV nexus? Well, we have to wait and see, don't we? I think there's been interference with drug delivery to areas of the world that need drug delivery for HIV infection that was caused by the COVID-19 pandemic. And exactly what the manifestations of that, you may know better than I do. We have not had problems in our country obtaining the drugs for HIV. They're quite easy to get here. But in other parts of the world where not the full therapeutic armamentarium was ever available, or HIV drugs cannot always be easy to get, this may be affected dramatically by COVID-19. Now, since Africa is the major part of the world where that's the case, where drugs can be difficult to get and the full armamentarium is not available, luckily, Africa has been relatively spared by the COVID-19 outbreak. But with the high case rate in South Africa of COVID-19, and as we saw with the recent block of the Suez Canal, it's hard to know what all these things are going to do to antiretroviral therapy and the availability of drugs. But you may know better than I do with you know, what you're seeing in terms of antiretroviral drug therapy. Is it possible for you to please share your presentation? Yes, I think it will be available to you. Why is it so hard to get HIV vaccine? You know, I've tried to explain to the best of my ability that it's because the virus, unlike other viruses that cause respiratory infection, like influenza, like COVID-19, that have most of their life cycle outside the cell, HIV, unfortunately, is like a virus that is mostly inside the cell, like Epstein-Barr virus or Cytomegalovirus, which we don't have good cure rates for and we don't have good vaccines for. So that's the difference. It's not like it's the only the only virus for which we don't have a good vaccine. It just joins a list of other intracellular viruses. In patients with prolonged viral suppression, is there room for therapy discontinuation? Any new information or hope on this? You know, it's an interesting question. And we have lots of patients who have been on treatment for years and years. I don't think there's any formula for telling us we can stop it. There are more and more convenient regimens, many once-a-day regimens. They're even looking at maybe every 6-month injectable regimens. But so far, I would be very, very careful about any literature that claims to show discontinuation is ever really feasible, because you would have to follow those patients for a prolonged period of time to see if the CD4 count steadily drifts downward and viral load begins to reappear. Next slide. I'm sorry, next question.
I think we don't have any other questions on the platform again. Colleagues, do we have any further questions?
Are there any other questions?
I think no other questions.
I'm not seeing any more. If there aren't any other questions, I'll say goodbye and thank you very much for listening. You will have access to this presentation and feel free to contact me about any questions you may have.
Somebody asked a question.
Then.
Do you still see Kaposi?
Bye-bye and thank you for listening.
So, colleague, thank you so much for your time and for your participation. Hopefully, we'll be bringing Prof back for subsequent presentation. Thank you. and have a wonderful day.